Hi, everyone. My name is Ann, and I'm the host of Taking Questions. And today I am thrilled to have on our program Dr. Katherine Saunders, who is an expert in obesity medicine. She is the founder of IntelliHealth, which is a comprehensive medical obesity platform. Thank you so much for joining us today.
Thank you so much for having me, and I'm really excited to be here.
Well, as you know, this is such a huge topic for women who are going through perimenopause and menopause. This is one of our biggest pain points, and we have so many questions from our community. So I am just going to jump right into it. And
Great.
the biggest question we have is, why do we gain so much weight in menopause? Even if we're not changing our diets and we're not changing our exercise routine, we're still gaining weight.
That's a great question that I literally get asked multiple times a day by my patients. Menopausal weight gain is infuriating for so many people, and it's just sort of inevitable for so many people. I have so many of my patients who have never struggled with weight in their lives, and now this is the first time, or even patients who have struggled with weight and, they used to lose weight and it was no problem to manage their weight. What I hear over and over and over again is the same strategies that used to work in the past no longer work anymore. And that's because it's actually, a change in our physiology as we get older. So several things happen, the hormonal changes, that we're well aware of. Body composition changes. So, as we get older, we lose some muscle mass. So our body composition changes in such a way that can make things more challenging. And then one of the big things that we focus on is something called insulin resistance, which happens as we get older. This is why so many people comment and describe weight gain specifically, in their midsection. This is very typical of insulin resistance. And many people may have researched this or know about insulin resistance, but I'm happy to, explain in as much detail as people would like, what this means and, what the implications are.
Mm-hmm. Is there an average amount of weight that you can expect to gain during this phase?
Great question. No, not so much. I mean, sure, we could look at data and, try to identify, but everybody's condition is so different. So weight regulation is actually extremely complex. It's not just, you hit menopause and you expect to gain 15 pounds. It's, what medications are you on? What is your sleep like? Do you have other weight-related medical problems like sleep apnea or prediabetes? So all of these different factors are at play. And so we can certainly look at average numbers if we, look up the data, but for each individual person, it's doesn't matter as much what the average weight loss is. It's really so highly variable and dependent on all these factors.
Right. I mean, it seems like it is such an individual journey, and weight means something different to every single woman, but we're all experiencing it. And so it is a frustration for literally everybody. Is there, and one question from one of our viewers is, I am in perimenopause and she's read about the menopause belly. Is there anything that she can do early on to prevent weight gain once she hits full on menopause?
Absolutely. There's a lot that can be done to, prevent weight gain and then to start, to identify it early and stop the weight gain from happening. I would say, the first place to start is looking at what you're eating. It's you probably see with your kids that they can get away with eating anything, and so many people were like that growing up. Some people were not, but at a certain point it kind of catches up with you and you feel like you can't eat the same way. So kind of making adjustments to your dietary strategy early on can be very helpful. Starting with low-hanging fruit, like trying not to eat anything that's packaged or processed or not real food. There's so much data that all of this just makes us more hungry and is not very nutritious. So, I consider that to be low-hanging fruit. Anything that's, very refined in terms of carbohydrates, added sugar, and just figuring out how to eat in a way that is just eating real food, focusing on protein and vegetables, focusing on food that's nutritious and also fills you up. And the most important thing is to focus on what is going to be sustainable, because any of these crash diets, anything that's too restrictive, is not going to last. And what's worse than just gaining weight and trying to manage your weight is losing and gaining and losing and gaining.
Right.
So that is something to avoid, and to instead figure out how to not feel like you're on a diet, but to figure out a reasonable and healthy and sustainable way of eating.
Is there a specific best diet that's great for women who are in menopause?
Again, it's so highly variable when you look at data on different diets. Um, it's the kind of thing where, yes, the best evidence may be the Mediterranean diet and, sort of a lower carb or low glycemic index way of eating. I wouldn't do anything that's a fad diet, anything that just doesn't seem sustainable. But when you look at the data, it's about figuring out the best strategy for each individual, and it's different for everybody.
So when I go on that no carb diet and I cut all breads and all pastas and everything carb related out of my diet, that's not a good idea.
It's fine if that's sustainable and that's just, what you do long term. But, this is one of the biggest problems with keto. It's so hard to follow. So sure, you can lose weight, but if you're just going to fall off the diet at some point and regain, then it's more of a
Right.
disservice. So, I think a lower carb way of eating is very reasonable. And if you're someone who can sustain something a bit more restrictive long term, fine. But I would definitely caution against being too restrictive.
Right, because then for me, I fall off the wagon and it just makes me feel worse. How do you feel about intermittent fasting? Because that's another one of these things that's the rage these days.
Yeah, very hot topic. Um, the data is interesting. There's a lot of mixed data. There's a lot of data that's pretty short term. So a little bit hard to interpret. There's so many different types of intermittent fasting. So, you can't really compare studies on different strategies as easily sometimes. I would say, again, different things work for different people. I have some patients who've tried it and it wasn't effective at all, and some patients who swear by it. And so I think the most compelling data in this area is more about timing. And so we know that as the day goes on, our bodies become more insulin resistant and we tend to store more calories as fat. If we eat later, we tend to, burn fewer calories than if we stop eating earlier. We tend to be more hungry than if we stop eating earlier. And we do store more calories as fat when we eat, let's say dinner at 9 p.m. versus dinner at 5 p.m. So what I find to be the most compelling data in this area is just shifting eating window earlier. Even if it's not every day, you probably get the same benefit if you do something 4 or 5 days a week than every day. And it's hard to do something every day. So even if a few days a week you can stop eating earlier, and have a longer window between when you stop eating, and when you start eating in the morning, that can be very helpful. So many people eat so late at night, and that can be, not so great for our bodies.
Right. So do you have a favorite breakfast?
So great question. I think breakfast is a good area of focus. There's some people who just don't eat breakfast and skip breakfast, and that's fine with me as long as people aren't eating the majority of their calories all later in the day. For breakfast, I would focus on protein. There are studies that show that if you start your day with carbs, you'll likely be more hungry, think about food more, and eat more all day long. So I talk to my patients a lot about eating protein in the morning. So Greek yogurt, cottage cheese, eggs, anything that's protein. Doesn't have to be typical breakfast food, but really trying to avoid, what most people eat, like highly packaged, processed, refined, breakfast cereal is something that's not as good of a choice. Bagels, waffles, pancakes, anything like that that's just really carby. Even oatmeal, if you have insulin resistance, your body might be so sensitive to carbs that even something like oatmeal can really spike blood sugar, and spike appetite for the day.
What about coffee? Please don't make me give up my coffee.
No, I love
I
coffee.
love my
Actually,
coffee.
Data on coffee is great. Coffee has shown to be, beneficial for our health in many different ways. It looks like it protects the liver. So I think, you can always overdo anything. If you're having palpitations and you're anxious and you're having medical problems because of too much coffee, then that's not a good idea. But in the absence of that, I think the more coffee, the better, as long as you're not adding sugar or anything sweet to your coffee.
Okay, so that's a great question, a great point you brought up, because I was using Splenda, and then I switched from Splenda to regular sugar, and I also use half and half in my coffee. And those are things that it's just really, really hard to give up. Is there a difference between the sugar and the Splendas, or one that's better for you, or do
Ugh.
I have to give it all up?
It is so hard for so many people to give up. I would
It's
say
my
if you can
favorite part of the day.
I know. I would say if you can minimize or reduce sugar or artificial sweetener, that's much, much, much better. Sugar causes blood sugar fluctuations. Sugar is
Mhm.
not great for our bodies. Anything in moderation. But artificial sweetener also, there's a lot of data showing that there are metabolic, implications of artificial sweeteners. They also just kind of train or they affect our taste buds in a way that make us crave more sweets.
Mm.
So in general, maybe they're a little bit better in some ways than real sugar, but neither is
Yeah,
wonderful.
that's great. And what about soda, like things like Coke Zero? You think you're getting the zero, and that's supposed to be great because it's Coke Zero. Is that actually hurting, not helping?
Same thing. I have a lot of patients who have very significant cravings, which is something
Mhm.
that can happen with excess weight. It's something that can happen with weight loss. And I have many cases of people who were drinking a lot of diet soda and then they stopped and it dramatically reduced their cravings.
Hmm.
So that's one thing that could be a benefit. Generally, when we're talking about anything that's just not real food or anything that's kind of chemicals, I tend to discourage this again because of the metabolic effects, the changes to the microbiome with these artificial sweeteners. There's more and more research coming out now about artificial sweeteners that I don't love.
So what would you recommend then that people replace it with? Water?
Yeah, water, club soda, unsweetened iced tea. A lot of my patients like having some kind of flavor. So, flavoring water with, lemon or, that there are water bottles that, have those infusers. You can put some fruit in.
Mhm.
But I would say, unsweetened iced tea, unsweetened tea, coffee, minimizing sugar and artificial sweetener if
You're killing
possible.
me. What about our relationship with alcohol? Does that need to change as we're hitting menopause?
Yeah. For women, the recommendation is to not have more than one drink a night.
Mhm.
If there's a little bit more than that, it's, probably not the end of the world. But I definitely would try not to drink, three, four more in a given night. You know, evidence on alcohol is a little bit mixed, and again it really depends on people's medical histories and what else is going on, but alcohol has calories in and of itself, and alcohol also makes us tend to eat more.
Mhm. Mhm. What about supplements? Do you recommend any supplements for women who are trying to lose weight?
I don't. I actually did a big research study, something called a systematic review, that was hours and hours and hours of work several years ago with a group of obesity researchers around the country. And we looked at all of the evidence, all the randomized control trials of supplements for weight loss, and found that there's so much bias. The results weren't even so great for most of them, or really not compelling. And what's more important that we didn't even study in our study is that supplements for weight loss can be very dangerous.
Mhm.
So a lot of the time, there are compounds that have been taken off the market, or stimulants, or amphetamines. So I would be very cautious of any supplement for weight loss. We have, medications that we use that have been very well studied and FDA approved and manufactured in a way that we are more comfortable with, but I would highly discourage any supplement for weight loss.
And supplement for weight loss, just to clarify, but supplements overall are still okay to take, like if you're taking a supplement for your hair, nails, and skin, or, to help mitigate your menopausal symptoms. That's not what we're talking about here. We're talking about specifically supplements for weight loss.
Specifically supplements for weight loss.
So there are so many medications now out in the marketplace to help with weight loss, like Wegovy and some others that we've heard of. What metrics do you need to hit to be a candidate for medication?
So when we look at the FDA criteria for candidates in whom these, medications have been shown to be safe and, who's indicated to take these medications, what we look at is a body mass index. So BMI, I can talk about that as a whole different topic, not the best, marker of health and weight, but we look at a body mass index of 30 or above, which is, the obesity range, or 27 and above. So 27 is within the overweight range, 27 and above with at least one weight-related medical complication.
What would some of those complications be?
Many. There are about 200, or probably way more than that, but at least 200 that have been identified, weight-related medical complications, including high cholesterol, sleep apnea, fatty liver, arthritis, high blood pressure, other forms of heart disease, big range, and many of the medical conditions that come along with menopause too. So, incontinence, things like that.
Mm-hmm. And what if you have a family history of it, but you don't suffer from it yet? So for example, you had a parent that had type 2 diabetes, even your sugar levels are high, but you're not there yet. Would that make you a candidate, or no, you have to wait?
So, I mean, if you look at the, actual, indication on these medications, it's 27 with at least one weight-related comorbidity. That being said, we really look at each person very, very, very individually and figure out, what their risks are and, what makes sense. So if someone is, let's say someone is on a medication that they absolutely need to be on, that's a weight-promoting medication that we can't change, and they're rapidly gaining weight, I wouldn't necessarily wait for them to hit the threshold. I would, intervene earlier to prevent the weight gain from happening. So everything that we do is just so highly individualized. But generally, if you call our practice, and your metrics are, showing a body mass index that's too low, generally people would not be eligible for, a medical intervention. They could always, work with a dietitian and then, identify if there's anything that could be, recommended for medical treatment.
Right. So let's talk a little bit more about that, because if you're not a candidate and you can't lose the weight, and you've tried and you've tried and you've tried, and you feel like you're just continuing to gain weight, you don't want to get to the point where you have to have medical help. So what can you do at this stage where you're frustrated, you're depressed, and you're trying to eat right? What else can you do to not become a candidate?
Yeah, so I think if you're trying to do all the right things, you're eating in a pretty reasonable way, you're exercising, and we didn't talk about exercise before, but that's another component that I'd be happy to touch on. So I would say, have a thorough evaluation, either by your primary care doctor if they're knowledgeable about this area of medicine, or by a specialist. And what we do is we do a very thorough evaluation, both in terms of weight history, medical history, labs, sometimes a physical exam, to identify all of the factors that are leading to weight gain and all of the barriers that are preventing weight loss. Because there may be something like an undiagnosed sleep apnea, or you might be taking medication that's pushing your weight up. So really not having a one-size-fits-all approach where you give everybody the same medication or you recommend the same diet, but figuring out for each person, what are the constellation of factors? What are these factors that are affecting weight?
What are the differences between Ozempic, metformin, and other medicines, and what are the side effects?
Yeah, so we have about 6 medications that are FDA approved for weight, and then we use a handful of others, depending on insurance coverage and, what makes the most sense for each individual patient. Metformin is something that we do use quite often. Metformin is something that may be appropriate for some people for menopausal weight gain, because it's good for insulin resistance. Metformin's been around for a very long time. It's a pill, it's inexpensive, it's generic, it's generally pretty well tolerated if it's prescribed appropriately and, with the right directions. So metformin is something that's not an unreasonable option for a lot of people. The other medications that are all over the news right now are, Wegovy, Ozempic, Mounjaro. These are part of a class of medications that have were initially developed for diabetes and then were found to be associated with significant weight loss. So some of them are approved for weight, some of them are approved for diabetes. These medications kind of mimic a gut hormone that we make that tells the brain that people are full. And so they're associated with, decrease in hunger, associated with some other, changes to our metabolism and changes to the way we, regulate our insulin level, our blood sugar level, and these are associated with pretty significant weight loss.
Mhm. And so what are the side effects of medicines like this?
So we use so many different medications that every medication has different
It's
side
different.
effects. It just really depends on what we're using.
Someone wrote in saying they're on Saxenda for over 2 years now, and she trains 3 times a week with a trainer who is very, very well versed in nutrition and movement. It's taken her 2.5 years to lose 45 pounds. It's been a bear of a time for her. But then she'll go and gain 10 pounds in a week. And that, it took her months to lose, and she's very, very frustrated. Any advice for her?
I mean, first of all, losing 45 pounds is wonderful, so she should feel very, very good about that. But this is a great question because it just shows that even after significant weight loss, we can't take it for granted, and that our bodies don't want us to lose weight. There are these anti-starvation responses that kick in with weight loss. And if she had not been on, if she were not on the Saxenda, she probably would have already regained all of her weight. But even with appropriate treatment, at any point, I saw a patient earlier today who went on a vacation and completely changed her diet, and now she has cravings, and she's never had cravings before. So things can change. So this phase of weight loss maintenance. So, weight loss is its own phase, and then maintenance is its another phase, can be tricky. And so it's important to continue the same kind of dietary strategy, continue exercise, check in with her doctor who's prescribing this regularly. And sometimes, things need to be adjusted, like maybe, a medication that is associated with more weight loss than Saxenda may be indicated, or adding in a different medication to target exactly what's going on here. But that's why this area of medicine is very specialized, because we're very crafty, and we do everything in a very individualized way to respond to how things are evolving over time with people's weight and their symptoms.
So we hear a lot about the birth control from women at this stage in life, which is just so ironic that at 52 years old, I'm put back on the birth control pill. One woman is 48 and she's in perimenopause, and she's still taking a low dose birth control pill, but she's struggling to lose weight. The same story, she might lose 5 pounds and then she gains 5 pounds. What is the role of the birth control in relation to weight gain?
So it depends on the formulation. Any kind of birth control, not what's generally used for hormone replacement therapy, but anything that's more progesterone based or more of an implantable injection situation, like the Nexplanon or Depo-Provera, these are associated with more weight loss than, combo progesterone estrogen pill. In general, the combo pills are not associated with significant weight loss, generally, but there is so much variability. And so it's really important to kind of pay attention to how you feel, what your hunger is doing, if you gain weight with any medication you're taking, not even just, hormones, and take it seriously. If you're feeling much more hungry, if, it takes more to help you feel full, if you're noticing weight change on the scale, take that seriously. And you may want to talk to your prescribing doctor about trying something different.
What about, I have someone who had a total hysterectomy when they were 26. So now that they're coming into menopause, what's the best hormonal natural treatment that they can do?
Definitely outside of my wheelhouse. I don't treat with hormone replacement therapy, but in terms of weight, I would say, talking to someone's prescribing provider or, gynecologist about what makes the most sense for them to treat what they're trying to treat. And then, understanding, just kind of watching their bodies closely and, weighing regularly. Everyone should, think about maybe weighing, at least once or twice a week during a period of time where they could be gaining weight, so that you catch it early and you can make a change if you're starting to see a pattern.
So I have one last question, and it's about estrogen. And having too much estrogen causes weight gain. In the middle, this person's writing and she's frustrated because having too much estrogen causes weight gain around the middle. Can you only be at your optimal weight when your estrogen is perfectly balanced?
I don't know that it's necessarily a direct correlation between too much estrogen and weight. Again, this is really complex. There's so many different factors that are at play here. I would, think less about the estrogen, for example, than, insulin regulation and, all of that. So everybody's really different, and it's about, figuring out what's going on here and, intervening early so that you catch weight gain before it's very significant weight gain, and just monitoring and paying attention to your body.
It is such an individual process, and there is no one silver bullet, one thing that one size fits all for this. If people want to get in contact with IntelliHealth, what is the best way to do that?
Sure. So our parent company is called IntelliHealth. It's a little confusing. We have a couple of different names, but our medical practice, which is all telemedicine, and we are in most states right now, is called Flyte. So FLYTE. So if someone may be eligible for medical weight intervention, again, sort of roughly those, body mass index cutoffs, it would be going to Join Flyte. So join, JOIN, FLYTE.com. And there is an intake form that can be filled out. And if it'll say if you're in network in terms of insurance coverage, if we're in your state, what your body mass index looks like, then an appointment can be scheduled from there.
Great. I will put all of that information too in the link below. I appreciate your time today so much. Again, as you know, this is one of the most frustrating things for women who are at this time in their life. And we have so many questions. I know we're going to have more, so I appreciate being able to reach out to you. And I thank you for coming on today.
Thank you so much for having me. And a huge part of what I do is perimenopausal and menopausal and postmenopausal weight gain. I actually did publish an article in medica.life. If you look up my name and menopause, or you can put it with the other information.
I'm going to put it in the link below.
Perfect. It's meant for providers, but there may be some information, and we do have, menopause content in our program. So happy to help anybody who qualifies for medical intervention, and also happy to come back if there are many more questions. So thank you again for having me. It's been a pleasure.
Thank you.